I'm going to get into a little bit of talking about what I did with the LDN book. Now, I'm going to preface this by saying that I use LDN for a myriad of things. I'm a board certified internist, so I know a lot. I know a lot about a lot of things that I know a little about many things. And that gets me into a lot of trouble because I am so interested in my patients, and I have used low-dose naltrexone for many conditions, much more than the topics that I talk about in the book. I co-wrote a chapter on chronic pain, and so I'm going to talk about that a little more. I'm going to be speaking at a couple of other events with other pharmacies. Speaking at one event tomorrow and one event on Saturday, and I'll be talking more about things that I do with autoimmunity and thyroid disease in one of those talks, for instance. But tonight I'm going to talk a little bit more about chronic pain, and I'm also going to talk about traumatic brain injury, which I wrote a chapter in the new LDN book too. I did want to talk about a couple of things too that came up. So Craig, are you sad that that you missed the heyday of pharmacy where you could treat ghosts in your blood with cocaine?
Well, yeah, heroin was the non-addictive opiate alternative to opium.
Absolutely. So Bayer came out with it, and they named it after the German for heroisch. That's how heroin got its name, which is German for heroic. So you could like live forever. They were trying to they had a whole slew, turn of the century. There was a show on Showtime or something. There was like some free trial. It was called The Nick, all about the turn of the century doctors. And, one of them was completely addicted to cocaine. And so they showed him like being rolled into bed where they were like getting him off cocaine by having him, shoot heroin. So that was and it was legal. It was not outlawed to be by prescription. I think you could get heroin without a prescription, I think until 1924, something like that. But so needless to say, Craig, your job is much harder because you can't like just legit give everybody cocaine and heroin and morphine and just, give it to them in a convenient cough medicine form. It's just like, what would you like today? Make me blind, It's just no fun anymore because there are rules. Anyway, I joke a lot because all day I deal with really chronically ill and suffering people. And I've suffered a great deal in my life. And I can honestly say the biggest gift for me is having chronic illness, to be able to live with joy, because for so long I didn't have any. I was so sick. And I have so much joy in getting to do what I do every day. And so I consider myself an ambassador for low-dose naltrexone and a teacher as a doctor. So with that, I have no ego and no bias. And there was something that you said, and even, so there are times where I don't agree with certain people, but if there's evidence, I have to look at it and read it, as a scientist. And so if something comes out with LDN that would say, oh, this medicine doesn't work, or it has a side effect, I would be looking very closely at it, and wanting the evidence. But I've had some very serious interactions with doctors, for instance, that have not only misinterpreted what LDN does, just as you said, but they have told my patients that they will go into withdrawal, including pregnant patients. And they have gone to the point of saying to my patient, heavily pregnant patient, that the patient will have withdrawal and the baby will be taken away from them because they need to be monitored because the baby will go through withdrawal. And I've had to send a strongly worded consult letter to say, this drug does the opposite. It is not an opiate. It is an opioid antagonist. It will briefly block that opioid receptor and thus does not cause any withdrawal. And I wish I could say that only happened once, but it seems to be happening more as more patients are asking about these medications and these alternative things. And there's more and more pushback without the research being done. And it's a knee-jerk fear reaction. And I am here to, you know, work with these doctors. I want to be able to educate, you know, and say, no, 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 it's a real thing and we can work together and coexist. And yes, there is a place for all of these rheumatologic medicines and cancer drugs and all of these things that we have in modern pharmaceutical drugs. But like you said, that was so profound. You said, if I had a condition that I could possibly take something that, you know, primum non nocere technique of do no harm, wouldn't I want to take that first? And that's how I went too. Of course, I didn't have a heavier duty drug choice. I wasn't given any choice to help me. There was absolutely nothing to help my pain or the symptoms that I was experiencing. So seeking out LDN was a kind of last ditch effort that worked. But you know, this misinformation that's happening is pretty profound. And you know, I have a hard time with the fact that our colleagues are prescribing DMARDs like, you know, methotrexate and these heavy duty immunosuppressants, biologic agents like water, and they don't think about those side effects. But they are suddenly terrified when an alternative doctor wants to prescribe something like LDN. And I have a very hard time with that mindset. And so that is my goal, is working with doctors and getting them out of that fear-based thinking, because, you know, anything that's different, you know, is scary and it's wrong. And we as humans don't like it if it's different, and that's to be understood. The other thing that I wanted to say is that LDN, aside from not being a panache, it's not usually the one thing that works, is that the results are different for every person. And the same thing with the side effects. And I wanted to actually give a little pearl for you and for the listeners that in the last few years, when I got started with this, I didn't have very many people react to LDN. But now I'm seeing sicker and sicker patients. And I'm seeing patients who have I'm doing more microbiome testing, for instance. And I now know that patients that have the largest bang side effect, that they can't tolerate LDN at all, no matter what the dose, is it usually means that they have an underlying infection. And namely, the things that I see mostly are rip-roaring yeast overgrowth or Lyme disease. And these are two things that I see, and the patients will be like, oh my God, this drug is the worst thing I've ever taken. And they will go on the LDN boards and they will like light the whole thing up. They will say this drug is poison, it's horrible. I mean, they have a massive reaction to it. And I say, no, it wasn't the drug. It was actually your body waking up and saying your immune system not being boosted, because LDN is not an immune boosting agent. And I want to clear that up. I really dislike when people say that. It is a gentle immune modulator. When I say, oh, your immune system woke up, your natural killer cells said, oh my God, what is that? And then mounted a response against something. These are patients that have low grade or very chronic infections, that their white cell counts, their natural killer cell counts, all of these things are depleted or depressed. And then you get a sniff of these immune agents that help to boost the body's own ability to do normal function. And it says, oh my God, what is that? And it starts attacking stuff and recognizing stuff. And then the person has a reaction. And so that's the time that I will then stop. I will stop and I will treat the underlying agent. Or if a patient, because I used to be the doc that would just put everybody on LDN. I'd say, oh my God, you've got autoimmune disease, start LDN. I am now starting to test for these things and trying to treat some of the underlying imbalances before I use LDN to give my patient the best shot of doing really well with it. And it's a really nuanced thing. Some people have Lyme disease and can do great on LDN. Some people have all these other things. I'm just saying, for people who have a really strong reaction, that might be the underlying piece that they need to step back in it. Because I have patients who are like, I tried it and I couldn't tolerate it. And I might have even done the liquid, you know, your secret sauce formula, you know, of liquid water, of liquid LDN. And they still react, you know, and I've done, and I, for the longest time, I was like, what the heck? Why are they so sensitive? But I'm not saying that's the end all be all, but it's definitely a pearl in my practice. And so, you know, all kidding aside, because I joke, I speak in memes, I speak in movies, I teach my patients all of these things, and I joke around a lot. You know, this practice of, you know, even using opioid medication, it, you know, aside from, you know, actually use of the poppy and use of opium and then laudanum, before it was distilled into morphine, and then codeine. And it's really funny, you read these stories of like the people doing the experiments on making these things. Naltrexone wasn't isolated. The experiments were being done around World War II to find other morphine-like agents. You know, in World War I, because they didn't have analgesics for these poor soldiers that were coming back with limbs blown off and all of these things. And I trained at the Heinz VA, so the very first building in the Heinz VA, actually it's a mile-long wing. It was actually built during World War I to accommodate those coming back with shell shock. And I just, the tremendous amount of suffering that these, you know, soldiers, well, what war has done throughout all the ages for humanity, but that necessitated the science of pharmacology and learning about how these things work: cocaine, heroin, opium, morphine, codeine. And then by accident, this guy who, you know, lost his job almost for a pharmacy, he figured out how to block the opioid receptor. They're like, well, you idiot, you just did the exact opposite of, you know, what we need, right? And it wasn't until, like you talked about, in the history, because I'm a student of history and I really love to learn about how all this stuff works. It wasn't until later that they were doing experiments in the 60s and 70s on being able to block that receptor, that opioid receptor, and the different receptors, whether they're selective versus non-selective, and how that might affect things. It wasn't until the 1970s that there were some thought leaders, namely Dr. Bahari and Dr. Ian Zygon, that started to have these crazy ideas that you could actually affect the immune system by affecting the opioid pathway. And then later on, they learned about this beta endorphin pathway, metenkephalin pathway. So beta endorphins and metenkephalin. So endorphins via brief blockade of the opioid receptor. So I just find it so fascinating that you know, we went from literally just getting a whole group of generations of people, frankly, addicted to these opioid medications for pain, with all of the known side effects of that, without any help for these people, now to having a variety of agents, including using ultra low dose naltrexone, which I was asked to talk about a little bit, because it's a really amazing agent to support people who are opioid dependent, either because they have chronic illness that necessitates opioid use, or they are working to get off their tolerance. So I want to talk a little bit about that. So there is, and you cited the same paper, there's some seminal papers out there. And you know, there's some really good documents now out there in the last 5 years, just since I started working on LDN and being a part of the trust. I really feel like we're now in this renaissance period where you've got Jared Younger and a bunch of researchers and Linda Elsie Good and everyone at the trust, and you've got a group of doctors who came about around the same time that I did, all talking to each other now and experimenting, saying, hey, you're using that. Oh, you're doing that twice a day. Oh, you're doing that 3 times a day. Wow, you used it for this. Wow. And then we go and we share ideas every year or every other year at these conferences. And I can't get over it. In 2017, I stood up there and I literally said, I prescribed 0.5 to 4.5 milligrams. I come back in 2019 and it's the wild, wild west. Everyone's doing all sorts of things and getting amazing results. And I was very dogmatic in 2017. I was not willing to prescribe in other manners. And now I'm able to have great insight that there are other answers, and papers like this have really helped. So in general, this is exactly what we were getting at, that And one thing about pharmacy that I think that I seriously believe that most doctors just take our pharmacology class, and then we go through residency, we learn about these drugs and things, and then we just block that out of our brain like it didn't happen. But there is and correct me if I'm wrong, something that's so profound to me about naltrexone and why I get infinitely just jazzed by it, and so I'm just so inquisitive about it, is that it really has a myriad of uses at a myriad of doses, and that speaks to both the the pharmacokinetics and the pharmacodynamics of this medication. So we know that just as a principle, giving a low dose of something and giving a high dose can have different effects. So we think of like when I worked in the ICU, we would give agents to help with blood pressure, like what we call pressors. And if you give a really, really low dose of that, it would have one effect. And then if you give a high dose, it would have maybe the complete opposite effect, which as a med student and as a young doctor, it blew my mind. It just really did that has an effect. But it's not only, so pharmacokinetics, what the drug does to you, but pharmacodynamics, what you do to the drug, right? Did I have that right?
Mm-hmm.
So,
yes.
So it's getting late and I want to make sure I speak correctly, but the general public. So if doctors don't understand that, you can't have hope for the general population to understand these things. And I feel like one of my jobs as a doctor or a teacher is to demystify these things and, make an idiot out of myself, telling funny stories and stuff if I have to. But I really feel like we need to understand our medicines, and we need to understand our bodies so that we can make the best informed decision we can on how to help ourselves, rather than just have this dogmatic approach of, the doctor tells you what to do and you do it, which it's hard because there is a lot of pushback too, because patients are getting more informed and more savvy. That patients come into me and they know exactly what they want, and they're very aggressive too. And there's a fine line. You want to be your best advocate, but you want to know how you can work with your doctor instead of telling your doctor what to do, or to have doctors shut down if they're not willing to, practice out of their comfort zone. Which I'm not saying that doctors should. I really do think that doctors should only prescribe to what they know. That being said, my hope is that in my work with the LDN Research Trust, that we can get the word out and hopefully gain enough support so that we can do these studies to further validate low-dose naltrexone as an important adjunct. So I'm not going to belabor the point about different doses, but again, the standard use is more for alcohol and opiate dependence, and we do use those doses. Now, I wanted to mention that on the market there is a drug called Contrave that they use, and I have mixed feelings about that drug because they use a higher dose of naltrexone that kind of goes into the standard realm, and it's naltrexone plus bupropion, and they increase the dose, so it's used for binge eating, to help with weight loss. But my concern is that opioid receptor, that level of blockade, that it might not be the best dose, And so when I've had patients come to me that want that medicine because they could get it covered by insurance potentially, and maybe they have depression, and they saw maybe a nurse practitioner who suggested that medicine. And I have a lot of mixed feelings about it. I haven't had patients do particularly well on that medicine. And so I prefer to use lower doses when I'm actually working on the inflammation model, because we want that. I don't think we hit upon it quite clearly, but the whole point of this is not that we're taking the drug to block the receptor. That's not the point. It's the actual 18 or so hours where there's that rebound where the receptor is free. And that's when the receptor says, oh crap, was I asleep? And then it makes more of your own endorphins and enkephalins. So beta endorphin and met enkephalin. And so I'm going to go on. And so just like Craig so beautifully talked about, not to belabor the point, that is the mechanism of action. And what's so amazing, and what I could live 1,000 years and still not understand fully, are all of the things that naltrexone, and using it at a low enough dose to enhance our own body's ability to make these beta endorphins, which can help with mood, with pain, with sleep, and with a lot of our immune system issues. But met enkephalins are also known as opioid-derived growth factor. And there are specific receptors for these metenkephalins, or opioid-derived growth factors. And I'm just going to use my example of what I know and treat a lot, that there are these receptors on the thyroid. So for instance, for patients who have an underlying thyroiditis, but maybe not complete destruction of the gland, if we use LDN early enough, along with lifestyle modifications, and figure out why a patient's attacking their thyroid, we might prevent them from losing their thyroid function. And it gives me great hope that maybe maybe the hell that I went through, and the fact that I lost my thyroid function at 19 and was sick for many years before that, maybe it was worth it, because I get to help young people now that maybe don't have to go through that, which is pretty amazing. And then of course, this total anti-inflammatory effect long-term, we dampen down those cytokines or those signals, and a patient can recover. And we get this whole body immune modulation where they're not attacking themselves so much. They're going on that pathway of healing, as you described. We can see that in those nice studies with IBD, where they, Penn State, they took it was 12 weeks in some cases that showed remission from ulcerative colitis. Pretty amazing cases. And then I'm going to talk a little bit more about microglial modification, as you said, with regarding traumatic brain injury. So this is something that I'm really working on right now. And I mean, when I say I'm literally working on it, I'm working on a manuscript right now on it. So it just reminds me of like when my kids are interrupting and I'm like, I'm a little busy right now. It's exactly what's happening. I'm trying to do all of these things at once. But I want to preview this, especially in the age now we have COVID, and we've got, we're now seeing autoimmune manifestations from people who've had COVID-19. And we can see that we have a group of people that are long haulers, people who have overwhelming cytokines and neuroinflammation, and they have manifested symptoms of chronic fatigue syndrome. We can see that with any virus. We can see that with almost any infection. And now it's just becoming more, for better or for worse, we have a much larger population of people that are going to be affected. And we actually have seen this generationally. We see this every few years with enterovirus with kids. We see this every generation. So what's so funny is in the 1920s, there were a whole group of people that got the H1N1 flu during the pandemic. And then right in the 1920s, they had this sleeping sickness. And we have it in different generations where there were different diseases that would come through and people would get very, very sick. And I'm trying to define this golden ratio with regard to inflammation, chronic inflammation post-infection. And I believe that it will take a myriad of soft pharma things. So things that we can do to help the immune system, like specific vitamin therapies and supplement therapies and low-dose naltrexone. And hard pharma, meaning one or two well-placed pharmaceutical agents that we need to pack a punch, for instance, steroids or a immunosuppressant therapy or a monoclonal antibody, for instance. These are specific targeted agents that we will use in addition to this soft pharma. And the thing that I am very, very frustrated with is the complete lack of openness of medicine, of our state of allopathic medicine, to share these ideas and come and say, look, it's not either or. It's not all natural or pharmacy. We need all hands on deck to figure out the pathophysiology of these problems that affect our worlds and come together and have independent people creating these protocols to help. in my experience with chronically ill people, and now many that we're going to be seeing come to the forefront, given this pandemic, we are going to need new solutions and not one drug. It's never going to be a pill for an ill in this case. And I want to illustrate that by the concept of endosomes. And this is really complicated, but I want to talk about how, and I want to introduce this as, you're going to hear this too, because a lot of people are talking about drugs for COVID, and you can talk about anything that needs to get into a cell. How does a cell take it in? It eats it. So we talk about cell eating, that is endocytosis. Cell drinking is something called penocytosis. But we're going to talk about receptor-mediated endocytosis. And I apologize, but I can't help it. I'm a microbiologist. You got like a really big dork on your hands. And I got the microphone, so you have to listen to hear me talk. So I know this is really boring, but this is really important for anybody that hears this. It's something that I'm still wrapping my brain around too. And think about this. Anything that we need to get into a cell, be it a medicine or nutrients or cell signaling like hormones, it tends to go through this process whereby a receptor on the cell has a ligand or a piece, a target, a component, a substance that is meant to dock there to that receptor. It can be a specific receptor where it fits like a key in a lock and it's very, very specific, or it can be general and multiple things may try to dock to it or look enough alike to it that it can dock. And now the drug companies know this. They know this very, very well. This has been elucidated for decades. This is how we know how drugs work. Now, this is also how viruses, for instance, attach and come into our cells. My job as a doctor and as a researcher and as a person that's interested in working with brilliant pharmacists and others that are developing solutions to chronic illnesses is to figure out how do we have healthy endocytosis or cell eating of the things that we want the cells to eat. And the priority, think about this. We have a whole generation. We've never been sicker as our youth. I've never seen so many kids with autoimmune diseases. I'm not talking about antibodies. I'm talking about 5-year-olds with Addison's disease or 10-year-olds with complete Hashimoto's, multiple nodules, complete loss of thyroid function. I didn't even see it to this extent 5 years ago when I started my private practice, but I'm seeing it now. And we have an epidemic of autoimmune disease and chronic illness that causes chronic inflammation and all of these illnesses that come from that chronic systemic inflamed state. And what I've been working on with a dear friend who's also part of the LDN Research Trust and working with others on is the principle of endosomal medicines for endosomal diseases. So cells are what they eat. You know, your mom always said you are what you eat. Well, our cells are eating too. So what if you have an autoimmune disease and your cells are eating antibodies? That happens. But what if certain viruses can create toxic antibodies? Well, your cell eats that too. So if you've got toxic antibodies that your cell is eating, then your cell is sick because your cell got food poisoning, right? So the job is, so we've got cellular food poisoning here. So we need to give a cocktail of medicines to feed ourselves to treat the food poisoning, right? Just like grandma would, right? You got food poisoning, grandma was awesome. Grandma didn't give you like Campbell soup crap. She gave you like real, in my family, it was Jewish penicillin. You got chicken soup from scratch. You got all the poor babies, you got the TV in the room, you got everything, you know? You got grandma taking care of you. So we need to give the grandma treatment to our endosomes. And we have to load those up. And guess what LDN helps to do? LDN, in my opinion, helps to reset those poisoned endosomes and give a reboot, like Control Alt Delete. And LDN is only one component of this, but it helps to reset those. And then we have to load up on those medicines. And then we have to keep those cells protected, help our immune cells work properly, and also protect, in the case of, for instance, coronavirus or other viruses that cause vascular problems, they affect our endothelium, or the lining of the vessels. And that's why people are getting strokes and heart attacks and all sorts of terrible things, because of these inflammatory markers that cause, it's called endothelial disruption. And they get chronic endothelial inflammation. If we can actually protect that from circulating toxins and pathogens, then we win. We win, but it's never going to be one drug, no matter what a politician says or a company says. And I'm up there too. Like, if I came up with a fantastic product, which I've got a lot of ideas for, and need a pharmacist to help me with, and need some pharmacists to help me with these things, it's not going to be easy, and it's not going to be one target. It's using things like low-dose naltrexone and other things to load up these endosomes and give us cellular medicine in a way that these cells can eat, not in the way that we just take and pray that it works. We have to actually target how cells work. And this was a huge aha moment for me in the last 6 months, because, you know, I'm like the rest of the world, mad about a lot of things. So when I'm mad, I try to understand. And I'm a microbiologist, so I call people who are smarter than me. And I say, please help me understand why we don't have a good treatment for certain things. And then I try to create solutions. So the cool thing is that I'm a microbiologist who deals a lot with autoimmunity. And I didn't realize it when I studied this, but our relationship to our environment, all the infections that we have, all the viruses, all the bacteria, the 10 trillion microbes in our gut. Do you know, Craig, that you are a freeloader? Your gut bacteria, there are 10 trillion bacteria in your gut, and one Craig.
Just going along for the ride.
Yeah, Craig is totally going along for the ride. And your microbes are like, man, that dude is not pulling his weight. We have so much more gene expression than that dude. So it's crazy. It's really crazy. So I spent all these years learning about how bacteria kill people, because that's cool. You know, like, how does anthrax work? How does tularemia work? How does, you know, how does Ebola virus cause people to bleed out of everything? I mean, like, that's what I wanted to do, but then I got sick on the way. So I became everybody's worst nightmare, because now I'm saying, wow, all of that stuff matters. So I got sick my second year, going into my third year of college. I did like an internship in Pittsburgh, and I don't like Pittsburgh. Not it's mainly because I'm from Cleveland and I can't stand the Steelers, but I really don't like Pittsburgh because it got me sick. So I got a terrible, and it was likely Epstein-Barr at the time, which is a huge trigger for Hashimoto's. But I had a terrible vertigo, and I was living alone. And of course, I wasn't a doctor. I was just a college kid, and I didn't know what to do. I had to have some stranger pretty much like dump me at the ER. It was a really bad summer. And I started to get symptoms of hypothyroidism after that. And we really are what our cells eat, you know? All of the viruses, all of the good guys in our gut, all the bad guys in our gut, everything. And so sometimes we can't control, you know, what gets turned on, but we can mitigate that autoimmune reaction. And by the way, we all have autoimmune disease. We all make autoantibodies, and we all make cancer cells, right? But we have an immune system that's able to keep that in check. And so when someone has a true autoimmune disease, or they get a true cancer, a systemic cancer, there are a series of things that had to happen for the immune system to not be able to control that. So those are big points that I wanted to make. And I want to kind of end by talking through a few other issues we've touched on about opioids. So again, with ultra low dose naltrexone, we use it mainly for opioid weaning now. And I use it at 1 microgram twice a day, but now I know more people are using a variety of doses, you know, for their patients. And I've had really, really, you know, great luck, because basically you're restoring that glial cell sensitivity, and then patients have less irritation of those cells in the CNS, and you can restore that, enhance the opioids effectiveness. You know, you basically are resetting those receptors, and the person can use less opioid medication and get better pain relief. So that's the goal with using ultra low dose naltrexone, as well as a reduced dose of their med. And I've had a lot of really, really, let me see. Yeah, I've had a lot of good luck. So basically, and if patients have other questions, you know, they can certainly call. I recommend talking to you or another pharmacist about that. That's well versed in the strategy. But basically, the rule of thumb is that if they've been taking opioid medicines for longer than a year, then it's going to be a slower taper than someone that had, you know, someone that had use on the order of months rather than years. So that's kind of a rule of thumb. But, you know, I have gotten people off of pain meds that their doctors said that they would never, ever be able to get off, you know, and that's just so incredibly humbling. I've gotten people off fentanyl patches. I've gotten people off of, you know, chronic oxycodone or Norco use, to the point where they were using other medicines to help with their bowels, and we had to retrain their bowels. And I mean, it's you know, and sometimes we don't wean them all the way off their opioid medication, but we significantly can hopefully reduce it. And that's something that I didn't even think existed, you know, before I started. And that's where there's a lot of pushback, because doctors don't want to put patients on opioids, aside from obviously clinicians are getting, you know, there's a whole registry. Clinicians can't prescribe opioids unless you're a trained pain specialist. And there's definitely, and I agree with having trained people to do that, because it's really difficult. It's to prescribe and to be a trained and knowledgeable opioid prescriber is really difficult. You know, a clinician has to have a lot of experience with that to do it well. But I believe that ultra low dose naltrexone has a great role. And we'll be looking at that, those new medicines that are coming out with those combos to see if they're better. I wanted to touch lastly on my other chapter that I have authored. The last chapter I did was a co-author with a pain specialist, but I actually did a chapter on traumatic brain injury, and it is a really profound issue. We're seeing a lot of patients who've had mild TBIs that have chronic problems later in life, and especially women, you know. I have a son and I have a daughter, and I now know what a Y chromosome is like out of the womb, because my son is just a maniac. He's just running and falling down and running headlong into things. And I'm like, oh my God, I'm running after him. I'm like, oh God, don't hit your head, you know. You know, my daughter was this dainty flower, you know, and my son's just a bull in a china shop. And I'm like, oh, so that's that. But it doesn't mean that girls don't get brain injuries. It's just they're far less often diagnosed. But basically, we're looking at levels of change of mental status, and we talk about, traditionally it's using the GCS or the Glasgow Coma scale, but I'm not going to go into it. But basically, that mild TBIs are really, really, really common, and so many that there's a variety of numbers that are thrown around, but millions of TBIs a year, and that's huge. It's not the number of people that die, although a lot of people suffer, you know, horrible catastrophic injuries and die of their illnesses. I'm talking about the people that are treated and released, or not treated at all. Like, you got your bell rung, and then later on, many years, have had issues that have never been put together. And TBI used to be known as concussion. We now no longer call it concussion, but people do, and that's what's really hard because there's no consensus. And I took a good chunk of time talking about this. As I got asked to write this chapter, so I had to do a lot of research. That's not my field, and it freaked me out. I was like, oh my God, all these years later, and there's not a consensus of terms or what these things mean, and we still use it, in sports. People talk about kids getting concussions, but now the proper term is traumatic brain injury, and we use mild TBI, and we actually define that is that the brain you have an impact, either a whiplash where you go back in front, and then the brain actually moves inside the skull. Obviously, it has nowhere to go. It hits, and then sometimes you actually get a contra hit. You get, with a whiplash injury, if it's hard enough, you go forward and back, and you can get coup and contra coup injuries that way, and it can be catastrophic, and you get brain swelling. Now, if you obviously get a catastrophic brain injury, that leads to altered consciousness, and people pass out, they're hospitalized because they have really crazy injuries. But we now know that the number one reason that teen girls have concussions is actually due to soccer. And they know that, and so I just had a patient this week. I said, did you ever have any injuries? She's like, yeah, I was in soccer from the time I was 8 until I was 21. She tried out for a pro team in Britain. She's a little girl, and she's a defense woman. And what did they teach her to do? They taught her to use her head. And she was hitting her head every single day from the time she was 8 years old, and now has serious sequelae from that. And so they say that they now believe that off-center blows are more likely to cause TBI than straight-on hits, and that's really significant. I mean, I was just blown by that. But I mean, all of us, as humans, you get your bell rung, you hit your head on something, you do something. But what happens? What is the pathophysiology of that? So what's so crazy is, and I teach this in my book, and I'm not the only one that says this. There are plenty of doctors that do this work. But we now know that a leaky gut equals a leaky brain, and vice versa. Why is that? And what does that mean? Now, I will be the first to tell you that if you as a patient go into your regular doctor and you say, Doc, I got a leaky gut, they will laugh at you and kick you out. And even worse, if you say, I got a leaky brain, they say, oh, you better go fix that. I'm being flippant because these are not the real terms, but I'm explaining it this way for a purpose. Now, we have a protective gut lining that is very, very, very thin, made of epithelial cells that are a layer thick, and they have tight junctions between them that are made of proteins. And if this is glue and they fit together like this, can't remove them. They are made of specific proteins like zonulin and actin and occludins. Now, zonulin and some of these other proteins are the same proteins that make up the blood-brain barrier. And so we know that if there is if there's any damage, including a gut problem or a brain problem, that you can have issues with the other side. And it's just really profound. So I want to talk about this a little bit more. So after a brain injury, if you get hit in the head, the tight junctions, they become dysfunctional, and you can get larger macromolecules like foods and other things, larger things, pieces of protein and stuff that go through and activate the immune system. We have our first responders in our gut, in our brain. We have glia, microglia, and we also have secretory immunoglobulins in our gut. These are the first responders. They go, uh-oh, that shouldn't be there. And they go and they attack. And then I did not know this, but after a brain injury, the mucosal lining can atrophy and it can die with damage within minutes to hours of having a brain injury. I wrote this, and I think I wrote something to the effect of this, but in presenting this and looking this up, it just is crazy. And then the blood-brain barrier breaks down, and you get these neuroinflammatory chemicals that go in and start to wreak havoc in the brain, and you can make antibodies in the brain, and you can have all of these issues. At the best, people with TBI, they have autonomic problems where their nervous system is messed up. They have disorders of visceral sensing and processing, impaired gut motility. How many people with chronic traumatic brain injuries have chronic constipation or diarrhea? They have problems with their sleep cycle. They have problems with their immune system. They have problems with their endocrine system. I have traumatic brain injury patients who have both Hashimoto's and multiple TBIs. And their doctor refuses to give them thyroid medicine because their thyroid looks normal. And I'm saying that they have injury to the hypothalamus and to the pituitary gland in the brain, and also the thyroid, and chronic inflammation. And so this leaky gut, or this intestinal permeability, equals blood-brain barrier dysfunction and hyperpermeability of that. And so leaky gut equals leaky brain. And chronic neuroinflammation over years can be associated with increased risk of mood disorders and Alzheimer's and other neurodegeneration conditions. We know that all of these things are connected, and you throw in whatever viruses you've had, whatever infections you've had in your life, that is fodder then. Those antibodies can enter and cause all sorts of issues. So it's a really big deal. And that leads to this, and why I use LDN in my TBI patients. So this slide is quite busy, but this represents a neuron, and the blue guy, the blue spidery guy, is a resting microglia. We can call him the M0 phase or M0 phase. These guys, these resting microglia in the brain, are kind of patrolling, and they're silent. They're just kind of patrolling, saying, "Hey, what's up? You good? Good. You good?" Because I'm looking at you, and I'm not sure if you're actually myself protein, or if you look a little funny and I should take a bite of you, I eat you. You're good? Okay, you're good. And so these guys kind of surveil. And then if there are things that activate them, including lipopolysaccharide, which is one of my favorite things to talk about, but these are pieces of sugar from a gram-negative bacterial cell wall. If that gets in the brain and the microglia gets a hold of it, it goes, "Oh crap, kill that now." And it activates and becomes a activated or M1 microglia that is pro-inflammatory, and that will stay on forever. That guy is gonna, even after he eats that piece of sugar, he's still on. Now, you rely on other signals to tell that microglia that it's safe and it can go back to going, "Hey, what's up?" Otherwise, it stays active. The coolest thing about LDN is that we believe, and Jared Younger's work needs to be continued to be worked on. And if this is true, it is one of the only known agents that does this. The drug companies are trying to make other things that do this. But LDN has the possibility of actually telling the microglia to go from that M1 state back to that M0 state and say, "Hey, it goes back to being a cool dude instead of being a shark." I don't know anything else that has the possibility of doing that. And then if I combine LDN with other things like omegas and gut work and vagal nerve exercises to help restore that tone because of chronic sympathetic nervous system activation, a person may be able to heal from that traumatic brain injury. And then we send them to a functional neurologist that can work on them and do exercises with them and help them, and vestibular rehab and ocular rehab and all of these things for people that have brains that have been injured. There are all of these things that we can do now, but they aren't being recognized. And this leads to, they call it PCS, which is this post-concussion syndrome. And they're all, you know, people talk about all kinds of things. So we talk about chronic TBI, and we talk about survivors. And right here, they talk about this concussion treatment, which again, they talk about all these things. And I think low dose naltrexone and omega-3 fatty acids should be the primary, like every single person that has a TBI should be considered for those things, you know. And I am very biased for it, but after doing this research, you know, we want to protect brains, and when these glia and when these immune systems are activated and you've got an open blood-brain barrier, this inflammation goes unchecked. There's just, if you don't do anything about it, it will just keep going until the brain is injured and has so much inflammation that can lead to neurodegeneration. So these cells, these cool dudes, hey, how you doing? I'm good, are suddenly active and they're just going. They don't stop until they die. And they burn brighter and hotter until they die. And think about it, if they're active, they're gonna die faster than the cool dude that's just like, sup, you know? Exactly. So if we can do, as doctors, if we can do cheap therapies that may help give us a chance to tamp down that inflammation, we should do that. So again, LDN for neuroinflammation is a huge passion of mine, and I hope it becomes a standard of care. There are other doctors at the conference that are using higher dose LDN, or you're using regular strength naltrexone or higher doses for when patients have PTSD that goes along with this. And there's just some really fascinating work that goes into it. But I just really believe strongly in that. And that's why I took on writing about traumatic brain injury in this book. So I hope that it can help others. And I hope that, you know, I hope that if the legacy I leave is that one other doctor is able to take up the mantle of this and do this work, then great. So that's about what my brain is doing right now, you know. So I'm Dr. Sarah Zielsdorf, and I practice in Chicago. My practice is Motivated Medicine, and this is where you can find me. And pretty soon I'll be hopefully having a podcast and some other stuff that we're going to be rolling out to, so if people actually want to get into my brain, which is really scary, which is more of like Homer Simpson's brain right now, and learn about what I'm learning about and what I'm into, I'm going to hopefully be doing more of that work.
Well, wow. Thank you very much, Dr. Z. That was a lot of information, lots of cool pictures and everything like that. And I really like how you started with the story about how naltrexone was kind of found by accident. Whoops. You know, a couple other drugs that were found by accident
Like
is,
penicillin.
like Rogaine and Viagra. Whoops. But
the Viagra story is one of my favorites. Actually, well, hey, this did nothing for my blood pressure. By the way.
Yeah, it's a strange side effect. But first, looks like we got about 10 more minutes, and we got 6 questions. I might be able to combine one of them. Yep. But I do want to thank the folks over at, well, first I want to thank Mark, our mutual mentor, who really helped me get into pharmacy in general, or I guess compounding pharmacy, and really opened my mind on low-dose naltrexone. I got to thank Linda, of course. Hopefully she's sleeping peacefully right now. I think it's past midnight already over there. And then got to thank, of course, Jeff, who set up everything over at the Roselle location, Dana, who's kind of like our producer right now, kind of getting us on the cameras and everything like that. And of course, all the patients and practitioners who are using this low-dose naltrexone, because if it wasn't for them, we wouldn't have any reason to try to get the LDN Research Trust Fund going, so that hopefully we can fund some of these studies and prove what naltrexone can do, and also understand what the limitations are and find out which conditions that this medication that has a lot of promise should be used for. So as far as the questions, let me see, one more just came in, but let's go with, oh yeah, it's kind of a combination. So um, one of the ones that's going to be probably for Dr. Z is going to be a patient, someone's asking, they have carcinoid syndrome and Hashimoto's with tinnitus. So carcinoid syndrome, for those who don't know, it's kind of like little tumors that can basically appear anywhere. They typically are sometimes in the digestive tract and send out toxins. So it's something that, well, hopefully, Dr. Z, what's your opinion about using
It,
LDN?
it's gotta be a multidisciplinary approach. So neuroendocrine tumors are really complicated. They're really complicated. But the theme about that of tinnitus, Hashimoto's, and carcinoid is that those are all three very inflammatory conditions that cause a lot of oxidative stress. So on the cell. So basically cells are inflamed, cells die. LDN can really help with that. And LDN can simply, I mean, if we were just going to take one of them, can definitely help with Hashimoto's. So we know that that's Hashimoto's is a kind of it's a prototypical state that we use LDN for. You know, it's kind of our bread and butter. So whether it's going to help the tinnitus, it depends on what's the cause of the tinnitus. Is the cause infectious? Is the cause inflammatory? Is there you know, TMJ? Is there you know, what's causing that? Is there electrolyte problems? Does she have Meniere's, which can be autoimmune? And if it's autoimmune mediated, then sure, the LDN might help, but it might not help that. And with carcinoid, she needs whoever she's working with, it would be primary treatment for the carcinoid in finding the source, and then using LDN as an adjunctive treatment. I think she would be an excellent candidate.
Yeah, it sounds like the bottom line is the LDN probably won't interfere with any medications that are used for that particular condition, but you don't want to be stepping on any toes. So certainly getting the practitioner who's responsible for the carcinoid syndrome on board, and of course, you know, displaying the side effect profile usually is what gets them on board. Another one for Dr. Z. Is there any condition any specific disease that you know that you just don't want to use LDN for? Is there something that, like a disease that you're just like, you just think LDN is not appropriate?
Really great question. You know, the big thing is transplant patients. You know, that's the biggest category. And then certain immunosuppressant agents, like certain cancer patients, like that are on checkpoint inhibitors. Those are the two that I mean, they're very specific cases. Like I don't see a lot of transplant patients at all. These are patients that there are certain like do not F with things in medicine. So I learned, like, there are a couple rules in the hard and fast rules that I learned in med school. Like rule number one, don't F with the pancreas. That's like number one rule in medicine. But like second is like don't F with the transplant patient. And, you know, and then subsequently, and obviously I'm being very flippant, but for real reasons, people who are on specific immunosuppressant agents for anti-rejection of a hard-earned and won transplant that they desperately need for survival is not something that I mess with. And then there are certain cancer agents known as checkpoint inhibitors where you don't want to, one of our colleagues, Dr. Angus Dudley, talks about that. It can be a problem using those specific agents. And you really this is why you have to work with this is what I fear, because there are lots of really qualified, nurse practitioners, naturopaths, other kind of prescribers that may not have this experience and may think that LDN is just universally safe and that there may be some situation. But there are very specific drugs like checkpoint inhibitors that should not be given because there can be interference with LDN use because of the mechanism of action. Other than that, I would be really cognizant, just like you said, for people with, say, PTSD, where it's not a contraindication to give LDN, but if it could cause pretty significant nightmares or flashbacks or conditions that that you want to you want to tread really lightly with, and also just give a lot of education to the patient before. And those are the type of people that I would really go low and slow, dose in the morning, work with their therapist, make sure that their sleep hygiene was rock solid and that they weren't in a flare of their condition. Other than that, I don't, aside from those other cases, patients who it's not a contraindication to take the drug, like patients that just can't take the drug. It's more, do they have any underlying things that make me hesitate before doing it right away? Like an infection that needs to be cleared, or some other treatment that they're undergoing that they should do first.
Excellent. Thank you very much for clarifying that. I do have actually a couple of people asked about the Epstein-Barr virus and what's going on with it's something that I guess just to blend some questions. That people who might have this virus and have antibodies for it, so it's hanging out. But they don't have any specific, they don't have like MS, or they don't have anything, that's diagnosed that could be a result. So what's your experience in using low-dose naltrexone and the Epstein-Barr virus?
So I just, a few big things on EBV. EBV is a jerk. It really is. It sucks. I'm sorry. It's 95% of humans have Epstein-Barr, period. It is one of the human herpes viruses. It's the gift that keeps on giving. A gift that keeps on giving. People think, ew, herpes, but there are a ton of herpes viruses. They're just different. So for instance, human herpes virus 6-7 can be roseola, which is a very, very mild rash that happens in most kids, most babies. It's not cold sore herpes. So Epstein-Barr is one of the human herpes viruses. And what most doctors don't understand, and what we're not taught, is that for a certain population, it can be either reactivated or chronic activated. And that can be rare. That's pretty rare that it actually is. And they're different conditions. Now, what I want patients to know is just having IgG antibodies, even high antibodies, doesn't mean that you have a chronic problem. If you have an immune system that's intact and you can deal with it, then there's not usually a problem. It's the problem where a person's immune system is that you're immunosuppressed, like from having another issue or having a disrupted gut, and then you can't deal with the Epstein-Barr and it reactivates. That's what I see in my practice. And so I used to treat the Epstein-Barr and do all these protocols. Well, it doesn't work if you don't have an intact gut. So you have to go back and you have to work on the gut first. And then, so the Epstein-Barr activation is a lot of times a symptom. At the same time, yes, it can be a primary trigger of autoimmunity, and it can reactivate and cause thyroid flares and all sorts of problems. And I see it a lot, but it's a very heterogeneous thing. It can look a lot. It can look like a lot, and just because you have it doesn't mean that you specifically need treatment for it. It means you need to work with someone who can look at it to see what's really going on. Now, LDN, I don't usually prescribe LDN just for someone with Epstein-Barr. I prescribe it for other conditions that might have been caused by having the Epstein-Barr infection. Does that make sense?
Oh yeah. No, it sounds like what you're saying is, so you got Epstein-Barr, you don't have Epstein-Barr. Sometimes it doesn't make a difference because you're probably not going to have many symptoms. But when this becomes a problem, it's because something else that was underlying is actually what is releasing the Epstein-Barr and letting it reactivate. So using low-dose naltrexone specifically for Epstein-Barr, no, but whatever caused that Epstein-Barr to reactivate could very well be treated with low-dose naltrexone. I got the quick one for me about the fillers and stuff that we use in our capsules. Just if we can use other fillers. I did show what I have and what the tablets are made out of, and Roselle and all that kind of stuff. And yes, as far as using the tablets and using different fillers, like you said, you might call and see like, can we do something? Can we change something? And yes, so we certainly can with something like tablets, which we make for thousands and thousands of patients. We wouldn't want to be messing around with the fillers on that one. But if there was a capsule that someone wanted, just a different filler, and we've used a number of them. I mean, it took a while before I settled on sodium bicarbonate, but we can use probiotics or something else that doesn't have any problems with you. So the fillers that go in to the medications that you're going to be taking can certainly be changed if needed. Someone is asking about if you're going to be having other engagements, other speaking engagements specifically about Hashimoto's, and if you got anything else coming up.
I will be. So, and forgive me, I'm speaking tomorrow. I believe I'm speaking more on chronic pain, more in depth. I believe Saturday I'll be speaking specifically an hour at least on thyroid and autoimmunity specifically.
And then you can get to these through the LDN.
LDN on the LDN Research Trust site for the events for the LDN Book 2. It'll show all of the events. So if you look for tomorrow's event and Saturday's event, I'll be speaking on behalf of 2 other great pharmacies.
Okay, and I guess yeah, we got 2 minutes. You could probably get to this one. It's just you're talking about the last in the last, you know, your second segment here about people using, you know, you said the LDN, but the omega-3 as well.
Yes.
Is there any specific type or purity or what you're looking for when it comes to the omega-3s?
Don't dose yourself. So I test and I don't guess. I look at omega-6 to omega-3 ratios specifically. And some patients are so inflamed they need a ton of omegas. They need grams and grams and grams and grams of it. And I never guess. I usually start, you know, a rule of thumb is an adult anti-inflammatory dose is about 3 grams of EPA and DHA. And there are several really, really good ones. Like, again, I would call your pharmacist up. You know, most compounding pharmacists have a few go-to brands that they use that are clean and tested for purity. You want a good, you know, a good triglyceride-based capsule, you know, a clean one that's vetted for purity and vetted so that there's no rancidity. And so I use a few specific brands, and kind of everyone has their favorite.
Excellent. And one thing I could add to that is that when you open up a cap, you know, some fish oils and it smells rancid, guess what? It's worse for you to take that than to, and as far as the fishy burps, as far as the fishy burps, if that happens, just throw it in the freezer.
No. If it's a fish burp, you get a fish burp, it means you got a gallbladder issue.
Oh, even like a little bit of a diagnostic trick there. So,
yep. So then ask us. So then I've got a couple that I like that cause less fish burps, but it definitely means we got to work on gallbladder support.
Oh,
I actually use tests to actually look at bile salts, to look at composition and help people get optimal digestion.
Yeah, and very well. So I really appreciate your time, and I really appreciate everybody joining us on this Zoom call. I hope we answered most of your questions. You know how to reach me at Mark Drugs. You can go to the LDNresearchtrust.org for all the information you need on low-dose naltrexone, or even look up Motivated Medicine, because there are good, competent prescribers, practitioners who have been using low-dose naltrexone for a long periods of time, and that's not all they use. Believe me, going to someone like Dr. Zielsdorf, who is going to be actually digging deep. You heard her say your first appointment with her is 90 minutes long. Let me know the last time you spent 90 minutes with a competent practitioner like yourself. So really, I appreciate everyone joining us on this Zoom call. I hope you found this informative, and feel free to reach out to LDNresearchtrust.org, markdrugs.com, or Motivated Medicine if you want to continue to increase your knowledge on the low-dose naltrexone.
Thank you so much, Craig, for emceeing. You did an amazing job, and thank you so much for representing Mark Drugs and all of us here in Chicagoland. And thank you to Linda for all the work she did in getting all of this set up for everyone, and her work on the LDN book too. She had to corral all these clinicians in writing this book. Okay, I can't imagine how much stress that was. But the book is out now, and also on the website there, you can get them from Mark Drugs. You can order them. There's free shipping in the US, and then there are lots of ways to get the book. Good bundles on both books. So tons of information out there. Thanks so much.